Vice Chancellor, NIMS University, Dr. Sandeep Mishra sir, and Dr. Sunil Sharma sir, Dean Director from Jaipur, City of Color and Culture. Steve Jobs rightly said, learn continuously. There's always one more thing to learn. With these thoughts in mind, I, Dr. Nancy Srivastava, Associate Professor, Department of Periodontology, NIMS Dental College and Hospital, Rajasthan, Jaipur, takes the privilege in welcoming you all for today's CD program on Perio-Plastic Surgery organized by Department of Periodontology, NIMS University, Jaipur. Let us begin today's program with a few incidentals or snippets of our NIMS University. We are all proud to be part of One NIMS, One World. NIMS University, established under NIMS Act 2008, is spread across 250 acres of land. This university is located beautifully in the arms of Aravalli Hills on the Delhi-Jaipur highway. Accredited by NAC, NIMS is a prominent educational institute known for its commitment in providing quality education across various disciplines. Established with the aim of fostering academic excellence, NIMS University has emerged as a leading choice for students seeking diverse courses, state-of-art facilities, and promising career prospects. NIMS University offers a wide array of courses across multiple disciplines. This university is a domain to about more than 10,000 students from across various parts of the world and is celebrating more than 1 lakh distinguished alumni. The university has put in its name many awards and achievements and has been awarded by numerous national and international associations. NIMS Dental College, established in 2006, aims to unleash the potential of the student and transform them into globally accepted personalities. All this is possible because of the vision of our founder and Chancellor Dr. Balbir Singh Tomar sir, a renowned personality. Sir is a tall stretcher himself in medical and healthcare field. A gold medalist and a proud alumni of prestigious Harvard University, USA and King's College London, Sir is a man of many experiences and exposures. Dr. Tomar travelled across the entire world, but his heart remained in India, where he wanted to build a world-class institute where all the facilities would be provided, and hence NIMS University was born. With this, now I request the honorable dignitaries to please come forward and occupy their places onto the dais. So please, I request Dr. Sandeep Tripathi sir, our registrar sir. Let us begin today's function with a devotional fervor, with our auspicious lamp lighting ceremony as a tribute to Mother Saraswati, the goddess of knowledge. I request the dignitaries to please proceed for lighting the lamp to mark the beginning of today's function. Our Vice Chancellor, NIMS University, Dr. Sandeep Mishra sir and Dr. Sunil Sharma sir, Dean Director, NIMS Dental College and Pro Vice Chancellor, NIMS University. They have conveyed their best wishes for today's function. It is our absolute privilege to welcome our Registrar, Professor Dr. Sandeep Tripathi sir, a very friendly person with a dynamic personality. With his unwavering support, guidance and wisdom, University is achieving new heights. I request Principal sir to please welcome sir with a floral tribute. We welcome you sir with all our hearts. We are honored to have a guest speaker, Dr. Videsh Suragimat sir, Professor and HOD Department of Periodontology, School of Dental Sciences, Karad, Maharashtra with us, who has wealth of experience and knowledge that he is generously going to share with us today. I humbly request Neeta ma'am to please welcome sir with a bouquet. Please join me in welcoming our principal, Dr. M.K. Sunil sir, a dynamic leader with academic excellence. Sir is a remarkable personality whose dedication, hard work and passion have led him to remarkable success. Sir, with your expertise, we aim to become better than the best. I request Dr. Rachna to welcome sir with a floral tribute. Welcome our head of the department, Dr. Neeta Bhargava ma'am, a very approachable person and an able leader. With her experience and expertise, we aim to grow in bounds. I now request Dr. Darshana to welcome ma'am with a floral tribute. Now, I humbly request our esteemed principal sir to speak a few words about the program and welcome the gathering. Please join me in welcoming our outstanding principal.
Good morning to all. The respected Registrar sir, Dr. Sandeep Tripathi sir, and other dignitaries, my good friend, and of more than 30 years I know him. We worked together and we have completed our post-graduation together. Dr. Videsh Suragimat, today's speaker, and our dynamic professor and head, Dr. Neeta Bhargava, and other faculty members and head of the departments, and my dear students. I think I welcome you all for this CD program series. I better call it as a series. We already started one CD program offline with a pan-India program with Dr. Amit, who has taken the upper hand and organized in the Department of Oral Surgery. So I think we have many more CD programs will come in future with all the benefit of enriching of the academic excellence. I first welcome our Registrar sir, who has given a support in organizing in each and every event of what you are seeing for the past few days after I joined. I think all the support of because of sir. So I thankful to him sir. I thank you for your support given in this others gathering. And our friend today, my Dr. Girish, has come all the way from Maharashtra. When I called him up few days back that you have to come for a speaker and you have to highlight the department efficiencies as well as your knowledge about in the field of periodontics. So he readily accepted our invitation and he has come traveled all the way, and it is very far away in the far, very deep, very closely, and where it doesn't have a bit of difficulty to come all the way from Maharashtra. And he accepted our invitation and he has been here. Thank you sir. And he accepted our invitation. There is no words to say. Professor Dr. Neeta Bhargava, what event you are seeing, it's all our efforts, and you can see that how it is coming out with good memories to you, and particularly in organizing this CD program. So I welcome you madam on this, and other faculty members of the Department of Periodontics and postgraduates put a lot of effort in organizing this particular CD program. And this program we are doing on a pan-India program. It is not limited only to the Rajasthan, it is be circulated to many states. That is the first foremost thing which we have been achieved, these series of programs. And we have many more programs is to come offline as well as the webinar series also. The good part of in the last two webinars, there is a international delegates have participated and international contribution also have been there in the webinar. So this is proud to be our the guidance and dynamic spirit our chairman sir Dr. Balveer Singh Tomar sir, who has supported us in organizing such events, and he has given a platform to do such events over here. I thank you sir, as well as I thank to all the Pro VC and VC sir who has helped in organizing such events, and furthermore we will come many more to come. Thank you.
Thank you sir for your kind words. Now it is my privilege to invite our Honorable Registrar sir to please come forward and enlighten us with his wise words.
Thank you so much. It is a privilege to be here and speak in front of you. First of all, I would like to welcome Dr. Grease. He is the renowned professor of the dentistry. I must thank Dr. M.K. Sunil sir, principal of the dental college, head of the periodontology, all the faculty members, staff, professors, and students. Definitely you will enlighten through this periodontology workshop. You will enhance your knowledge, enhance your skill, so that patients from the different corner of the country, corner of the Rajasthan, you will treat perfectly. On the behalf of the university, I will assure you to provide every support, any kind of support, whichever you required by the dental members. And I hope all the HODs of the dentistry and principals कि next year कुछ बड़ी conferences करिए, different branches हैं आपके पास, 9 branches हैं, बड़ी conference करिए, बाहर से लोगों को बुलाइए, knowledge exchange हो, knowledge explore हो आपका, और even जो out of the countries हैं, वहाँ से जो हमारे alumni हैं उनको बुलाइए. और एक छोटी सी डॉक्टर जयप्रकाश जो कवि थे, उनकी एक कविता है, 2 लाइन की मैं सुनाना चाहता हूँ कि जीवन का उद्देश्य नहीं उक्त भवन में टिक कर रहना, जीवन का उद्देश्य नहीं उक्त भवन में टिक कर रहना, किंतु पहुंचना उस सीमा तक जिसके आगे राह नहीं. To you, all of you, सीखिए और पेशेंट्स, मरीजों की सेवा करिए, अच्छे से उनका इलाज करिए, जहाँ भी जरूरत पड़े इस ड्यूरेशन में, चाहे जो BDS के स्टूडेंट्स हैं या MDS के हैं, जो भी लगे कि आपको ये स्किल एक्वायर करनी है, आप अपने प्रिंसिपल सर से बोलिए, हम अरेंज करेंगे. थैंक यू सो मच.
Now filled with more energy now. Life cannot be rich without gratitude, so here we are expressing our gratitude. We have mementos as a token of appreciation for our guests who took time out of their busy schedule to grace our occasion and make our occasion into a memorable one. I request our principal sir, Dr. N.K. Sunil sir, to please present a token of appreciation to registrar sir. Now it's a time for vote of thanks. I request head of the department, Department of Periodontology, Dr. Neeta Bhargava ma'am, to deliver the vote of thanks.
Very good morning and warm greetings to you all. On behalf of Department of Perio-Plastic Surgery, I take the privilege to propose vote of thanks for the people who contributed to this program. First and foremost, I would like to thank Dr. Balveer Singh Tomar sir, Chairman and Chancellor, NIMS University, for allowing us to organize this program. And I am gratefully thankful to our Dr. Sandeep Tripathi sir, Registrar, NIMS University, for taking time and gracing this occasion. Sir, today we had an opportunity to hear you. Your words are inspiration for us for our future endeavor. Thank you so much, sir. And also gratefully thankful to our principal sir, Dr. M.K. Sunil sir, Principal NIMS Dental College, for his rock solid support and encouragement to organize this program at the time in the year. Thank you so much, sir. I also extend my thanks to our guest speaker of the day, Dr. Girish Durnimal sir, Professor and Head of the Department of Periodontology, for his active participation in the CDE program. We appreciate you, sir. Your knowledge will add a glory to this event. Thank you so much, sir. A program like this cannot be organized overnight. It requires a lot of planning and bird's eye detail for organizing this program. So I'm backed up with a team of faculty members, Dr. Nancy, Dr. Rachana, Dr. Darshana, who constantly worked on every details of this program and made this as a grand success. All the faculty members, HODs and postgraduate students of my department and other departments, and also the students who have come from various other colleges also to take part in the CDE program. I hope you best utilize this program and upskill your surgical methods in perio-plastic surgery. Thank you, Madam. And the IT department for their technical support. Thank you so much. We'll begin the lecture in another 5-10 minutes. We'll take 5 minutes break and we'll come back for the enlighten us with the vision of Dr. Pradesh Thank you.
Faculty members and my dear students, a very good morning to all of you. We are honored this morning with the presence of our guest speaker, Dr. Perio-Plastic Surgery. Sir is a professor and head of the Department of Perio-Plastic from the Dental Sciences, College of Dental Sciences, Krishna Vishwavidyalaya at Satara, Maharashtra. Sir completed his BDS in 1993 and MDS in 1999 from KLE's Institute of Dental Sciences, Belgaum. Sir also did diploma in human resource development in the year 2005 from International Council for Management Studies, Chennai. Sir has a total experience as a teacher of 24 years as a UG and PG teacher. Sir has published 125 research papers in national and international journals. Sir has authorized with 5 textbooks and 2 chapters and also have 5 patents and 35 copyrights to his credit. Sir is also an active runner and has participated in many marathons and also encourages the students for the physical activity. Sir, we look forward to a wonderful session for learning the newer concept of Perio-Plastic Surgery from over to you, sir.
आप लोग अपना जूम करें तो ये तो कोई नहीं आ रही मेरे को मेरे को मतलब नहीं आ रही आपको ये सेंटर जूम कर रखा है सेंटर बिल्कुल आपने कर रखा है मेरे तो पूरा रिकॉर्ड आ रही है अच्छा आपको जूम आपका जूम होता अरे मैडम कुछ नहीं आ रहा आपका कुछ नहीं आ रहा
you get a pleasant approach from the other person also. This can be attributed to lot of. This can be attributed to even our parental perspective and dental, even the rest of teeth and the gums are part of a smile in the process. To introduce, periodontal practice surgery procedures are performed to prevent or correct anatomical, developmental, and traumatic or plaque-induced defect deformities of gingiva, adult mucosa and bone. This was the definition given by Sir Dibart. There are a lot of definitions on periodontal practice, but I found it the most appropriate, explaining all the aspects of the periodontal practice surgery. Initially, mucogingival surgery, Friedman in 1957 gave the term as mucogingival surgery. He tried to relate it to 3 points. Basically, shallow vestibule, upright serum and attached gingiva. He tried to correct these defects and he called it as mucogingival surgeries. But in later 1993, okay, 1993, this Miller gave a definition. He changed the definition to Perio-Plastic surgery. And in 1996, the World Workshop on Perodontology accepted this term and they included these certain elements into the periodontal practice surgery. Basically, periodontal prosthetic correction, round lengthening, ridge augmentation, aesthetic surgical corrections, coverage of included root surfaces, reconstruction of patella, aesthetic and surgical corrections around the implant. Because the implants came into picture, they included the implants also into the periodontal surgical procedure. Exposure to unadapted of teeth and for orthodontics. Whenever you are doing orthodontics, some breathing may be there. Whenever there is some impacted canine or a premolar or a when you expose, that also will come under periodontal plastic surgery. The term mucogingival therapy is a broader term including lot of other elements just than periodontal plastic surgery, where non-surgical periodontal therapy which are done to correct the mucogingival defect also come into the mucogingival therapy. It is a broader term where you do orthodontic corrections or prosthetic corrections, that also is included. But I am sticking to periodontal plastic surgery today, wherein I will be dealing with surgical procedures done to correct the periodontal problems. Periodontal surgery by the definition here is the surgical procedure performed to correct, eliminate anatomic development, traumatic disease issues, defects of gingiva, adult mucosa, bone. This was the term accepted by World Workshop in Perodontology on 1996. This is still the term that is being used. I try to give a broader perspective of surgery, but very include other angles of the perio-plastic surgery. What is a smile? Okay, the basic facial aesthetics is not just dependent on the teeth or the. Basically, it depends on the lot of other things here. There are three things that are interpupillary line, lip, and zenith point. Zenith points are the most corner points of the teeth. Okay, these become the most important element for the golden root of the smile. What they say is proper alignment of teeth, symmetry of face, and proportion of face are important. Most of orthodontical students also can be using the same angles of the for the correction of the orthodontic teeth. Okay, there are what they say. What they try to give the best smile is when you have 11 mm of central incisor, 10.5 mm of lateral incisor, and canine at 11 mm. Means the central incisor and the canine it should be at the same line, and 0.5 to 1 mm should be slightly lower compared to these teeth in the lateral side. This is what the aesthetic smile according to the lot of authors which have done a lot of research on this. What are the indications for perio-plastic surgery? Basically there are 5 indications. Inadequate attach gingiva. Attach gingiva has been a lot of discussion has been taken on the topic attach gingiva, whether it is needed, not needed, whether it is how much should be the amount of attach gingiva. In case of normal people, 3.5 to 4.5 is the millimeter that width of the attach gingiva in case of maxillary anterior, 3.3 to 3.9 in case of mandibular anterior, and it is least in the premolars, 1.9 in the maxillary and 1.8 millimeter in the mandibular. Gingival research is also one of the causes for the perio-plastic surgery. Shallow vestibule, which can lead to the gingival recession, are also corrected through this perio-plastic surgery. Upper inferior or high fill attachment are also corrected through basically the perio-plastic surgery. I'll be explaining all those surgical procedures later. I'm just trying to give you a brief outline. Aesthetic deformity is around the gingiva. Means when you have unequal gingival margins, you correct them with the surgical procedure. That's called as perio-plastic surgery. What are objectives of perio-plastic surgery are basically correction of attached gingiva, correction of gingival recession, shallow vestibule, high fill attachment or upper inferior. Aesthetic surgery is to give aesthetic appearance, and tissue engineering is one of the part new angle I'll be trying to include in this thing, where I'll tell you how tissue engineering has the new concept that has been added into perio-plastic surgery, where you can get a predictable outcomes. What are the ecological reasons for the inadequate attach gingiva? Deep pockets extending till the mucogingial junction, mostly suprabonic pockets. Okay, you understand supralveolar pocket and the pockets which are above the crectabullar bone, they tend to cause inadequate attach gingiva. Vigorous brushing can lead to abrasion and the reduction in the attach gingiva. Aberrant high frill attachment tends to pull the tissues and reduce the amount of attach gingiva. And shallow vestibule, when you have a shallow vestibule, it basically reduces the amount of attach gingiva and creates more recession also. Insufficient by birth, some people are, it is not equal in all people. I gave you the brief idea of 3.5 to 4.5. Some may have more, some may have less, but it is a general rule that some people are born with inadequate attach gingiva. The literature update on this is Lang and Low 1978 gave a lot of context. Okay, they try to, I told you there are many authors who have tried to explain that there is a need or no need of attach gingiva. Lang and Low said that at least 2 mm of attach gingiva is necessary to maintain a good gingival health. Neighbors in Atlantic said the presence of attach gingiva is necessary to maintain a gingival health. Okay, and both said that average thickness, the thickness, I am not talking about the width, I am talking about thickness of gingiva should be 1.25 millimeters. Okay, and later in 1980, Friedman 1982, gingiva health can be maintained by independent of this. There are contradictory thoughts to the same thing. Some people realize that there is no need of attach gingiva at all. If you maintain a good oral hygiene, with the good oral hygiene practices, you don't need attach gingiva. So these were the proofs that were arrived after long-term studies. Friedman in 1992, inadequate gingiva leads to pocket formation, improper pocket closure. Due to this, what he said was, whenever there is an inadequate attach gingiva, the pocket opens up and causes fast accumulation, ultimately leading to more recession and inadequate attach gingiva. This is what is the theory that was given by this fellow. Mehta et al. Okay, 2010. These people made a long-term studies and found that there is no need of attached gingiva in case of we can maintain the present adequate oral hygiene. Okay, the gingival tissue around teeth restoration undergoing orthodontic may require attached gingiva. See, orthodontic students who are there, they might require attached gingiva whenever there is shallow vestibule or inadequate attached gingiva. What happens is this: when you put a band or a bracket, it will cause more recession whenever there is inadequate attached gingiva. This is what is already proved. Okay, so you try to increase the attached gingiva whenever you try to insert patient where there is inadequate gingiva. You can increase the attached gingiva by different procedures and go in for orthodontic treatment. Kolte et al. Okay, this is an Indian. Okay, this is an Indian author who did very nice study on. They came up with this conclusion: younger age group have significant thicker gingiva but less width of attached gingiva. Older individuals have more attached gingiva but thinner attached gingiva. Gingiva was found to be thinner in adult, that is what I told, and it is found to be less in case of females than males. The mandibular arch had thicker gingiva but lesser in width of attached gingiva. This was done by an Indian author. Okay, Perio et al. Gingiva bite had no, but ultimately they said that even the width or the thickness of attached gingiva does not make a difference in attached gingiva if you can maintain a good oral hygiene. There is one more now comes this Turner. Okay, this guy did a nice study and he came with a different definitions of attached gingiva. He gave two scenarios. Okay, whenever there is attached bone is correctly placed, amount of attached bone is there, and there is amount of tissue or above the correct bone is there, you can measure it from the mucogingival junction till the pre-gingival groove or the septal sulcus. This is the attached gingiva in case of a healthy scenario. But in case of scenario where we have a infrabony defect here, let us see, this is there is an infrabony defect around the implant. At that time, you cannot measure it from the defect point because already the defect point has gone into the bone here. The depth of sulcus is already into the sulcus. So what he said was, you should measure the attached gingiva from the crest of the alveolar bone till the mucogingival junction. This is what was the differentiation. This fellow did a nice study and came up with this idea because a lot of implants started coming in and implants were being placed and they tend to have certain amount of bone loss whenever you have implants on the teeth. There will be some certain amount of bone loss happening and this was the definition that he relied on. You can measure it from the crest of the alveolar bone to the mucogingival junction. Literature update on attached gingiva, this is Greenstein and Caraway, they said that because around dental implants have advantage with respect to various clinical parameters. They say whenever you have a better attached gingiva, you tend to maintain a better oral hygiene or easy to maintain the plaque status or the caliber status. But what ultimately this contradictory points are also there. The presence of two implants around dental implants in erratic patient means not well maintained, plaque maintained patient, you should go for increasing the attached gingiva in those patients. Most of your prosthetic PGs or periodontal PGs or orthodontic PGs, you go to place implants. But whenever the inadequate attached gingiva, it tends to create a recession or a pocket formation whenever there is inadequate attached gingiva. They say you should go in for increasing the attached gingiva with free gingiva after some procedure and then only try to place implants. Or after the placement of implant also you can do the same procedure. Kim D et al. She said that indicate that subjects with a thin and narrow gingiva teeth have more gingiva recession compared to those with a thick end with a good attached gingiva. But there is no published evidence. There is no published evidence. If you increase the attached gingiva, there will be no recession. The proof is not there. Evidence-based dentistry, what we follow these days, there is no proof that increasing the attached gingiva or the thickness of the tissue will not lead to recession. There is no proof as such. Okay. Okay, what are the advantages of implant? Attached gingiva. It basically enhances the plaque removal and around the gingival margin, improves the aesthetics, gives a pleasant appearance, reduces the inflammation, Whenever we have inadequate adhesion, there is invariably inflammation due to plaque accumulation, and this can be reduced by increasing the adhesion. Reduce the inflammation on the dental implants of the same procedure can be there. Tight adherence of gingiva and underlying bone and tooth will basically prevent plaque accumulation and recession that can occur due to those inadequacies. Reduce of the plaque accumulation also will be seen. Minimize the effects of functional force to stabilize the muscle fibers on the gingiva. This will prevent the recession from happening. What are techniques to increase the gingiva? There are a lot of techniques and lot of things. I'll come to the conclusion. Okay. There are different techniques mentioned by repositioning of gingiva by neighbors, pushback technique by Goldman, complete duration of periodic separation by Bohnen, apical repositioning by Friedman, and free gingiva graft. This is a gold standard. What they realized, okay, a lot of studies were done and a lot of procedures were carried out and a lot of surgical procedures were carried out to increase the gingiva. But they found out that the long-term results of increasing the gingiva were only seen in case of whenever you augment it with a free gingiva graft or a continuous graft. Simply dimming the vestibule or increasing the gingiva is not going to be long-term predictability. So there was a creeping attachment taking place. They say you should always go in for an augmentation process available, human origin, animal origin. These can be used to increase the gingiva and they are for a long-term result rather than short-term gains. There were a lot of studies and I told you the gold standard is free gingiva graft, but there were even setbacks in the free gingiva graft. Free gingiva graft, what when Agarwal did a study and these people did study in 2015 and they said that when you do a free gingiva graft, the post-operative discomfort, because you are doing it in two sides, palate you harvest the graft and the recipient side you pull at the graft. Both there is a lot of pain experienced by the patient. The pain scale was more in case of whenever you use free gingiva graft compared to any graft that was basically harvested from animal or human origin. That like ASL or matrix or collagen matrices. And the poor color patch. What happens is free gingiva graft tends to maintain a tire patch appearance when aesthetically unpleasing. In the aesthetic zone, in the canine to canine aesthetic zone, they give a tire patch appearance. This was a negativity of the gold standard procedure, that is free gingiva graft. And donuts are morbidity, means you are harvesting the graft from the palate. This will basically, there will be a lot of tissue necrosis happening in the palate, maybe sometimes bone exposure also, bone loss also happening. This is one thing that is the negativity of using a free gingiva graft. And this Karen Miller came up with a new surgical procedure called as MURF, okay? Basically it's called as modified apically reposition flap. This is easy to execute, predictable color match, decreased surgical time, no need of second surgical site. I'll show you this procedure. This is a simple procedure which was previously done by one Clark. Historically the Clark was also, the procedure was there. This procedure, okay? What they do is they just deepen the vestibule, maintain the periosteum over the tissue and suture it at the periosteal level here like this. And they see they got good results. This is the latest at 2015 and they found this we can try it out. As a pattern student, this is easy surgery. Only difficulty is giving the sutures here. These sutures are difficult. You have to give periosteal suturing. This suturing is, if you can learn it with a micro surgical procedure, you can do a good procedure, good application of this in your daily practices. Easy. Patient comfort is there because there is no second surgical site. It is not painless compared to the free gingiva graft. And then now I will come to what are problem associated with the gingival recession. What will happen in case of gingival recession? Basically, it increases the plaque and calculus in the recession area. Because of the toothbrushing, there will be difficulty in abrasion creation will be there. Maybe it can be due to high filling attachment. Position of the tooth, if it is labially positioned, you tend to have more amount of recession happening compared to a tooth that is placed lingually or palatally. Okay. Orthodontic tooth movement. Whenever you are doing orthodontic tooth movement, whenever you are trying to bring it labially, whenever there is thin amount of tissue, there is bound to happen, it will cause gingival recession in those regions. Improperly designed partial dentures. In the dentures that are there, when you have clasps that are there which are holding on, they may impinge on tissue and cause recession. This is what is the etiological reason for the gingival recession that takes place. I told you that these are the faulty tooth brushing, one of the technical thing that is most in almost 60% of the cases, faulty tooth brushing is the etiological reason for recession to happen. This is already proved, okay, almost 60% of the cases. Mechanical perspective may be oral piercing like this, tongue, these are the nowadays they tend to wear them. These also can impinge the tissue and cause recession in the inner aspect of the teeth, okay. And maybe sometimes it may be due to localized inflammation or subgingival. Whenever you are trying to endo-PGs are there or prosthetic PGs, whenever you place a restoration subgingivally, always and always it will cause inflammation and it will lead to recession. So try and keep it equimarginal or coronal to the margin, any restoration. If you are trying to go in for a subgingival restoration, try and do something called as tooth lengthening or you reduce the bone level and take to a recession, create a false image of in the restoration and create it rather than going it subgingival. Whenever you try to do subgingival restoration, be very careful. All your even class 2 cases, whenever you fill them with which are going deep into the tissue, they tend to have recession and pocket formation in those regions. Okay. This is the generalized disease like generalized periodontitis, there is aggressive periodontitis. When you get arched bone loss, in those cases also you tend to have recession happening. Bone loss this ultimately all periodontal diseases which are aggressive in form, they cause bone destruction. Bone is required as a tissue support to maintain it. When bone is lost, the tissue also moves with the same thing. So you tend to have recession whenever you have bone loss happening. What are the consequences of gingival recession? What will happen? Well, let there be recession, I don't mind, but ultimately they lead to very irritating aesthetics or unpleasant aesthetics, gingival bleeding and plaque retention, inflammation of the gums, hypersensitivity. Recession always will have your dental pupils will open up and you can have hypersensitive reaction to cold and hot. Okay, those ultimately have to either you do filling or some correction to correct them, or that means you augment it with some procedure, physical graft or dental graft, and cover the recession. Dental caries can occur because of the recession and dental implant. Lot of people are placing implants. These implants exposure, the lengthening of the sun will happen in case of recession that is there. What are treatment options for the gingival recession? Free gingival graft is one of the procedure. Free connective graft, this is CDE or subepithelial connective graft. It's a gold standard procedure for recession coverage. Okay. And pedicle graft like laterally positioned or coronally positioned or similar floor, this is given by term. I'll show you the photograph later. Subepithelial connective graft, this is the gold standard. GTR, using the guided tissue regeneration to increase the bone as well as the tissue. This is very optimal, very ideally speaking it should be happening, but creating the space for this and healing, while healing, the amount of blood required is sometimes becomes less. So whenever you place bone graft, GTR, over that you coronally position, the amount of blood reaching the graft area is very less. So predictability is not very much there unless you are very done with microsurgically, very nicely done. It is not very predictable procedure. Pouchet telescopic, this is one nice procedure, easily doable. I'll show you. And but only thing is some skill enhancement is required to do this procedure because you are creating a pouch and tunnel and passing the fringe graft or a connective graft. It is little technique sensitive. Coronally advanced tunnel technique, also this also is like a pouch and tunnel wherein you advance the coronally also and put a graft also, connective graft. These are technically sensitive procedures, but as you start doing them, initially you might find difficulty when doing perio-plastic surgeries. When you start doing them, they are easily possible. Problem associated with shallow vestibule. Okay, what happens when you have shallow vestibule? Basically, narrow genoplasty, there will be increased reduction in the carotidial gingiva, inadequate attached gingiva. High fill attachment can be one of the cause for the shallow recession. Positive pull syndrome. Whenever you do this pull test, when you do that, your marginal tissue will start moving, and this will create plaque accumulation, calculus formation, inflammation, recession. all those possibilities are there, and inflammation will be there. Plaque removal becomes difficult in those areas, and in oral hygiene maintenance is difficult in case of shallow bed tube because your brush will not be able to completely clean those areas. This is what is the negatives of the shallow bed tube. What are the techniques? Okay, there are a lot of techniques. So these are all old techniques, 1950s, 60s techniques. But I'll tell you what's something. Kanjan technique, Godwin technique, or lip shift technique, Clark technique. The Clark technique is that just like a mark. I showed you that mark. It is somewhat like Clark, but he was completely denuding that with a bone, and it was causing a lot of bone loss. So that has been outdated now. Abedman's technique also is very good, but not easily possible. What I realized is all these procedures in long term, after 5 years we follow up the patient, there was creeping attachment, whatever that they had done would fail in the end. That is why they are saying always augment with a free ginger graft or a connective tissue graft. Okay. On the lingual vestibular, you tend to do this Toronto technique and cardiac. These are very technique sensitive and not very approachable. On a lingual side, very difficult to do procedure because of bleeding and those complications. But there are techniques which can be done for this area. Problem also is the aberrant frame or the high fill attachment. Basically, frame is a fold of mucous membrane usually with the enclosed muscle fibers that attach the lip and cheek to the alveolar mucosa and or gingiva underlying periosteum. Basically, frenum is, everybody will have frenum. The high frenum attachment becomes a problem. Whenever you have a frenum, basically, this guy said that in 2010, inflamed gingiva is due to poor oral hygiene because of the high fill attachment, difficult to maintain, plaque accumulation, inflammation, gingiva recession can happen, midline diastema, whenever there is something called a papillary penetrating frenum. This will always have a diastema of the maxillary anterior. Okay, it can happen even in the mid dentition also. High mandibular frenum causing gingiva. This ultimately will lead to recession. These were this guy did a study and came up with these conclusions. What are treatment options for the aberrant frenum? There are two methods, frenotomy and frenectomy. Frenectomy as a procedure is complete excision of the frenum with the bone exposure. Whenever you expose the bone and take out all the collagen fibers or the muscle fibers until and expose the bone, it becomes frenectomy. Frenotomy is a simple procedure, you just excise it and suture it. Okay, but in case of papillary or papillary penetrating, you should always do frenectomy. In case of gingival or the mucosal type of frenal attachment, you can do frenotomy. But whenever you have a papillary or papillary penetrating type of frenum, you should do frenectomy when you expose the bone and suture it. There are different techniques that are there in case of frenectomy also. It's basically conventional frenectomy, you use it with a hold it with a clasp and cut it. There's a Miller's technique, which was these are outdated now. Okay, Perio-Plastic, jet plastic, using electropottery lasers are nowadays the in thing. But I would like to tell one thing: whenever you do frenectomy with laser, always suture. Okay, suture those. I'll show you that area where you should put. Whenever maybe next slide is there. Whenever they have to open up the trapezoidal flap open, tissue open, the upper part you should always suture. Otherwise, what happens, there is some amount of creeping attachment happening. The laser people say that when you use laser, it will heal itself. But my conclusion is that you should always suture whenever you are doing frenectomy with lasers. Okay, on the upper part at least, so that it will not once again creep back and once again the frame goes back to its original position. That is one negativity of without suture. Then I will talking about aesthetic surgeries now. Aesthetic, basically, the aesthetic zone is the canine to canine region. The distal part of canine to distal part of canine is considered the aesthetic zone both in maxillary as well as mandibular teeth. Okay. The maxillary anterior teeth are basically these teeth are visible. That is what they say. Patients are concerned that this patient comes with maybe some recession or a gummy smile or certain issues which you need to do aesthetic surgeries, which also will come under the perio-plastic surgery. The therapeutic ginger condition or aesthetic zone basically you can do with what is root coverage whenever you have recession. Papilla reconstruction, you construct whenever you have the papilla lost, you tend to create black blinders in the anterior. That also can be corrected using papilla reconstruction procedure. therapy to correct gingival dysplasia. I told you gingival display or gummy smile. You do gingivoplasty or gingivectomy and give a nice curvature or the aesthetic design. I told you, you do lateral incision slightly lower than the central and the canine and central canine, and you get 11 millimeter of the central and incisor and canine should be visible, so that it becomes a nice aesthetic smile. Ridge augmentation with a soft tissue graft. Whenever you do the prosthetic rehabilitation, you tend to have those ridge defects. Mostly ridge defects, for prosthetic point of view, you need to create bone also. But in some cases where there is already advanced bone loss, you cannot increase the amount of bone that is there. So you can go in for ridge augmentation procedure with soft tissue grafts. I will be showing that in my second presentation. What are factors influencing the outcome of a root coverage procedure? What are the factors that will ultimately say that by procedure that whichever procedures I am talking, how are they predictable? How are they going to be there for long term? They can be, there are three factors, okay? Patient related factors, site related factors and technique related factors. The patient related factors, poor oral hygiene maintenance by the patient. With all your perio-plastic surgery, with all your best procedures, if the patient is not maintaining good oral hygiene, ultimately it will fail. It will lead to recession or inflammation and cause the whole tissue loss. Toothbrushing trauma. If you don't, whenever you are doing perio-plastic surgery, you should educate the patient to use a simpler roll technique. Roll technique is the best technique to avoid you should never advise BAS method for recession cases. BAS method is basically a sulcus printing method. It always causes recession because the bristle ends are in the sulcus. That will ultimately lead to recession. So you should avoid giving them BAS method. They say roll technique is an easy technique, just to best technique for those patients who are having thin tissue or are prone to create recession. Okay. Smoking and tobacco use. In India we have tobacco in non-smoked form. Even those tobacco pouches wherever they keep, there you tend to have defect. Whatever perio-plastic surgery you do, that will always tend to fail in case of smokers and tobacco users. And site-related factors. What I said, this was Miller gave a classification class 1, 2, 3, 4. I think this was taught in your undergraduation. Okay, 1, 2, 3, 4 is 1, 2 is wherein your there is no interdental tissue loss. 3, 4 is interdental tissue loss is there. What I say is level of interdental pattern support. Class 1 and 2 you tend to get 100% results. You get possibly that 90 to 100% of the whatever procedure that you do, you tend to get those results. Class 3 and 4 are not predictable. You cannot expect 100% result at all. Maybe 50-60%, whatever. If you covered about 4 mm of attached Java, you might expect 50%. There are only 2 mm of coverage rather than 100% coverage. Okay. Wide recession. Wide recession more than 3 mm width. Okay. More than 3 mm, they tend to have less amount of predictable result. And deep recession or deep recession is here. 5 mm and more. Turnout gave this thing, okay, about the interdental contact point to the bone. If you have more than 5 mm, you tend to have less predictable results. Okay. Position of tooth, labially positioned tooth, okay, labially positioned of tooth and are prone to have more amount of the failure in the recession coverage procedures, whatever procedure that they do. The thickness of tissue. There, a lot of studies were done. I told you 1.5 mm is the minimum good attached gingiva should be there. Whenever you have thinner tissue, because of the labial placement of tooth or by genetics also there is a possibility of thin tissue, they tend to have unpredictable results of your recession coverage procedures, root coverage procedures. And technically, what are technique related factors? You can do what they say is thickness of the graft. I told you free gingiva graft and tissue graft. 1 mm is the optimal thickness for the connective tissue graft. Whenever you are harvesting connective tissue graft, I'll show you those slides. 1 mm is the optimal thickness. For a free gingiva graft, 1.5 to 2 mm is the optimal thickness. Okay. That okay. And tension while closure. When you are closing the flap, if you have a pull, if you are not given a releasing incision inside the tissue, and there is always a pull happening, it will ultimately lead to recession. Whatever procedure you are doing, you are trying to do coronary advance flap with the connective tissue graft. Whenever there is a pull happening, it will tend to pull the tissue back, and your recession cover procedure tend to fail. Okay, and placement of coronary flap 2 mm above CA. What they say is, whenever you are doing coronary flap, what they say, you should place your the coronary flap 2 mm above the CA. Certain amount of recession is bound to happen, and it will recover that much amount of. You should always try and keep the coronary flap 2 mm above the CA. Thickness of the free geograph, 2 mm is, they did lot of studies and found 1.5 to 2 mm of the free geograph, good results are there. Thinner version of the free geograph, you tend to have lesser results. But connect geograph, minimum, the adequate width is 1 mm. Now I am talking about tissue engineering. Tissue engineering has become the latest science in dentistry or even medical science also. There are 3 things that are there here. The first one is the scaffold. You require a scaffold. You need cells. You need cells to incorporate in the scaffold, and you need these cells to become active. They just cannot. You can just by placing cells, they will not be active. You need activators to those cells. You require. These are the 3 factors. There are triads for a tissue engineering. This is the future of the wound repair, where we can get a predictable outcome, including with the perio-plastic surgery. The methods of tissue engineering are basically there are 2 methods: passive engineering and active engineering. Passive engineering is basically the use of GTR based techniques or a barrier membrane. You create a barrier membrane and expect the certain cells to grow, or the periodontal ligament cells and basically the bone cells to come into the picture and form new bone, new periodontal ligament, and this we expected. We try and avoid the epithelial and connective graft, the connective cells coming into the picture. That is what the barrier membrane technique or a GTR. Biology based, this is ADM is very good, okay, but expensive. Acellular dermal matrix is basically a allograft harvested from the cadavers. Very good results. We did a study and we found very good results, even better than the SCTG. SCTG, subepithelial connective graft, is considered the gold standard, but our results found that ADM was far better than the SCTG, but the material is pretty expensive. It is by 8 millimeters, almost around 9,000 to 10,000 rupees. And nowadays in India, the import it is banned. ADM not easily available. If you are doing some research work, you can buy them, but for a non-general practitioner, it is not very cheap. Okay. Then there is something called active engineering. Is you can use enamel matrix derivative. EMD is basically a porcine origin. Okay. This is porcine origin, wherein you tend to get those enamel proteins which are harvested from the pig erupting teeth of the pigs, and this has shown very good results. Jucheli is one father of this perio-plastic surgery kind of thing now these days. If you can see lot of YouTube videos of him, nice videos, okay. And this guy does all the procedures with the use of EDTA, the root conditioner, and the use of EMD. For every procedure he uses. But even this is the expensive material to use. But maybe Indian economy will grow, and someday we will get it at a cheaper rate and we will start using it on every patient. But Duchenne uses it, every patient uses it, okay. And these are growth factors which can be there, recommend to have platelet derived growth factors, and cell therapies can, these are the PR or the PRP. Mostly PRP is not much to use, no. PRP is easy to, you can just take the blood of the patient and you can use that as a source of your the regeneration. Okay, that's very good. We have done a study on that also. PRF and compared with the SCTG, we found PRF was equally, I'm not saying better than SCTG. SCTG is gold standard. PRF was equally possible. But this is one, because in case of when you use PRF, you are avoiding the second surgery from the palate. That is one advantage of using PRF as a material for the regeneration. And you can use autologous fibroblast, these are cell therapy based, okay. And bilates, BLCT, this is bilate cell therapy, human fibroblast derived HE, these are dermagraft, okay. This is also one of the graft which is porcine origin, and this has also shown very good results whenever you are trying to do perio-plastic surgeries. These are the methods and tissue engineering, of tissue engineering, okay.
Yes, sir, just a second.
Okay. Some terminologies as a postgraduate you should know because when you start reading literature on perio-plastic surgeries, you tend to get these terms and you wonder what are these terms. Okay. NCCL is non-carious cervical lesions. Lot of things are being done now. Endo-PGs should be learning the terms because abrasions are non-carious lesions. There is no caries. Okay. These terms are for abrasions you tend to do GIC or composite and then do perio-plastic surgery. This is one thing. These are terms that I want you to know. CF is coronary graft that you might see. FGG is pharyngeal graft. CTG is subepithelial conditional graft. DGG is de-epithelialized pharyngeal graft. Means usually advocates, instead of trying to harvest connective tissue graft, which is technique sensitive, what he says is you harvest the pharyngeal graft, take the pharyngeal graft with the epithelium and do de-epithelize it with the microsurgical blades. Okay. This is one new thing about this one. Tunnel technique is the TUN. ADM is acellular dermal matrix. I told you this is basically allograft. EMD is NML matrix, which is a xenograft. Okay. GTR is guided tissue region. Vista. This is one new technique that is being incorporated. Vertebral incision subperipheral tunnel technique, where you create a tunnel and push in the tissue graft. This is Vista. And OPS oral plastic surgery. These are the terms that are there. LMCF is laterally moved coronally advanced flap. Ducheri says that whenever you are trying to do coronally advanced flap or a lateral display flap, you can place a connective tissue graft also over it, under it and place it over. So you can get a predictable result with these techniques. These are my references. You want to take down, I will give my pen drive to somebody to use it. These are some good research materials are there here. I would like to acknowledge these people because I am using lot of photographs from the internet, from some textbooks. I would like to acknowledge those people for, I have not taken permission, but I use those photographs, that's what I want to acknowledge them. And there is virtue in work and there is virtue in rest. Use both and overlook neither. Means, don't just keep listening to lectures, try and contemplate on what I am trying to teach you. This is what will be my last slide. I will be taking to the next slide, next presentation, wherein I will be talking about lot of surgical procedures. This was theoretical aspect of the first slide. This part was mostly theoretical aspects. I will be teaching lot of surgical procedures, incisions, and all that in the next presentation. Time for a break. If you have a break, or if you have already had tea, I can start.
Part of the lecture, I think our students must have benefited understanding the importance of attaching gingiva in maintenance of periodontal health. And in the second part, we look forward to many surgical procedures. So gear up yourself, have a tea, come back, and let's join for second part of the lecture. Now let's start for our second part of the perio-plastic surgery, in which we'll be dealing mostly about the surgical aspects of perio-plastic surgery.
Welcome back. Okay. One thing I want to view back what is perio-plastic surgery. Perio-plastic surgery is defined as a surgical procedure performed to correct, eliminate animal anatomical, developmental or traumatic deformities of gingiva or alveolar mucosa. This was the basic definition of perio-plastic surgery given in 1996. Now, when you go into war, you should have a arsenal that is good enough to fight. Okay. What I want you to learn at this juncture is, simply saying I do plastic surgery is not going to help you unless you have a certain set of instruments which will help you in doing the procedure. What all will you require? At this juncture, you know all this number 3 blade, PP handle, number 2 PP handle, and this is number 5 because it's got a round body, number 5. And this is double slot blade, means whenever you are trying to harvest a connective graft, you can use this, but not very accurate. Okay, the graft that you harvest with this blade, double blade, is not accurate unless you have a thick amount of palatal tissue. It's not very predictive in doing the procedure. But you require number 5A because whenever you are harvesting the palatal graft, you require curvature. Sometimes the palatal vault is high. Whenever the palatal vault is high, means it's a good case for you. Shallow palatal vault will have thin tissue high palatal vault or a big palate vault, we will get a good amount of correct tissue, can harvest a good amount of graft. So whenever you have a patient with palatal shallow vault, you should try and avoid injuring those vessels which are very close to the bone, okay? And you should always choose patients which have higher palatal vault where you can give good predictable free ginger graft or correct tissue graft. You will require these instruments. And then the blades, okay, mostly all of you know about number 11, 12 and 15. But there is one more blade called a 15C which is very nice. Whenever you are doing microsurgery or you are using loops to do surgery, you will require a thinner blade, okay. This one is a nice blade. It's the same BP blade only, but the blade is shorter compared to the number 15, and this is very good while harvesting the graft or while preparing the recipient site. Very good for this one, okay. These are number 12D. This blade is sometimes useful, not, but it is got double edge, so you tend to cut unknowingly some areas. But number 15C is the one blade that you will require for your surgical procedure. And these are different type of elevators, elevators. You will require all of you know all these elevators. But 25-1 is this one blade elevator is good for whenever you are harvesting a palatal graft. Okay, this blade. Okay, this elevator is very good while harvesting a palatal graft, cutting it out or taking it out. Very good one. These are the forceps or pliers that are used because you don't want to harm the tissue that you are harvesting. Your normal chital forceps or forceps, the tweezers, they tend to clip and harm the tissue that you are harvesting. So you should use a traumatic type of tweezers or pliers to hold the tissue. So you might require these instruments. And you require graft pliers. This is very good because they don't have clips. They just hold on the tissue while you are trying to say you want to deepitalize the ginger graft. This is a good plier, and you will require corn suture plier. This is one thing you should have in your arsenal or in your surgical set. You should buy corn suture plier. Whenever you are trying to suture the graft or the connective tissue graft or frigio graft, you will require that suture to pass. It is very fragile and very slippery. Any graft that is harvested, it is very slippery. So you require this corn plier to suture while suturing. It is very useful for suturing. Okay, this one thing is very useful. You should have corn plier. I am not sure about other pliers, but you should have corn suture plier in your instrument set. And these are basic parts of your needle holder. Okay, these are. But for you should buy these Castro pattern needle holders because all your microsurgical instruments are these. Whenever you are trying to hold, but the using Castro pattern needle holder is little skill that you should develop. Okay, it's just when you just press it, it will open up. So that once you start using them, you learn how to operate with them. This is one thing that you require whenever you are doing perio-plastic surgeries. And the suture materials. Okay, you tend to use lot of sutures. Silk suture is not at all advised in case of perio-plastic surgery because it is too thick. The needle is too thick. It is mostly round body that is there, but not very good for us. You should always use vicryl sutures, which are slightly expensive but very predictive. Okay, this is very good. You tend to use the number 3 to 5 for the perio-plastic surgeries, or if you are using loops or the microscope for your surgery, you can use number 6 and 8 to even 9. Number 6, 9 is very good. But these sutures are very delicate. If you, while knotting, if you pull, they will tear off. So very delicately you have to use them. The thinner the suture, delicate they are, and you should learn the skill to use them without tearing them. That is one thing you learn through your practice. When you start doing the procedure, you will learn that. And techniques to attack ginger are basically two attacks. Basically, ginger augmentation applied to the area and ginger augment color to the area, meaning the research storage. Okay. Frigio graft. Okay, where do you harvest the frigio graft? Mostly you harvest it from the palate, hard palate, because it is a keratinoid tissue. Lot of graftings were used, skin grafts were used, mucosa grafts are used. All these fail because skin graft is keratinized, but the hair follicles, they tend to grow hair at later stage. So skin graft is out of question. Oral mucosal graft, which is non-keratinized, is not good at all because it will not help you in the tissue. So the best area to harvest a graft is mostly the palate, okay, or the rugae area sometimes. But this is the best graft area to harvest. But where do you harvest it from? From the canine till the canine, from the internal canine, mostly rugae area. So it is less, there is less blood supply. So you should not choose a graft from the rugae area. You should choose distal to canine till the medial to the distal to the first molar. That's the maximum limit. You should not go beyond the second molar area because these are greater pattern vessels are there. Even slightly cut, it will bleed like hell, and all these surgeries there. Whenever you harvest a graft, you should see that you don't go more than, whenever trying, let us say you are trying to harvest a Phrygia graft at 97, not to incise more than 1.5, and always choose patient which have thicker tissue because the greater pattern vessel is deeper patient. If you cut the vessels, it will bleed and your whole procedure becomes very complicated. You can't control the bleeding. It will mostly, you need a good assistant also. When you start the surgery as a first timer, most of you are PGs, okay? When you start the perio-plastic surgery, don't become hero and say I do everything and start. Use a good assistant. Think of all the possible complications that can arise. Mostly bleeding is the worst complication because it will, when you cut that vessel, it will start bleeding and you can't control it. Even with the pressure pad, not very good. I tell you techniques to stop bleeding, but very difficult to manage when you start bleeding and you become apprehensive. The blood flow is so much that it will fill up the full mouth. You have to keep on putting pressure pad. So try and use a good assistant who can hold the vessels or the vessel while doing the procedure. Use a good assistant, okay? Prepare the classic technique of a Phrygia graft is you prepare the recipient site. I'll show you how to prepare that, and obtain the graft from the palate area and transfer and immobilize the graft and protect the donor site as well as the recipient site. I'll show you how it is done, okay, later. This is a schematic diagram of a Phrygia graft, okay? How do you harvest it? You basically, I told you, prepare the recipient site. Means you have de-epithelize all this tissue. There is a recession here, you de-epithelize all this area. You create a de-epithelialized tissue like this and you create a template. You can use aluminum foil for surgical blades covering that area. That's also aluminum foil. You can use it and create a template for yourself. You create a template and use that template on the palate, stick it to the palate and cut those margins, Phrygia graft. Use that, stick the palate, show you the next slide. You cut out the margins and you slice from one corner, you start slicing. It is difficult sometimes for initially, you have to first incisions are the difficult part. When you start cutting it from like this, you go on cutting it and harvest the graft. The graft is harvested, you protect the donor site. That becomes, you should always think of a Hollis plate or a modified Hollis plate with a C class, 2 C class, and no need of using a label bow. And use it to fix it to the area wherein and donor site you protect it and use that graft to the recipient site because you already measured it, taken it, and use a banging suture. The suture that is used here is called a banging suture. Means you are trying to reduce the dead space in between the graft and the recipient site. More the dead space or the blood clot in between the donor side, the harvested graft and the recipient side, less is the possibility of it to revascularize and become very well adjusted tissue. So you should always use a banging suture or a suture that is called this suture to see that there is no dead space created, and you protect it with a perio pack like a co-pack or any pack. Mostly co-pack is the best one at present, okay? Or Wonder pack, or some people tend to use cyanocolate. If you are very comfortable using cyanocolate, cyanocolate is a Fevikwik. Have you been using it? It is Fevikwik only, it's a liquid form. It tends to flow wherever. If you know how to use it properly, you can use cyanocolate also. But first timers, I would not suggest use perio pack like co-pack, easy to do. This is one surgical area about how to see. What you do is, there is some amount of inadequate gingiva in this region here. Okay, you can see there is pull syndrome happening here. Okay, what you create is you create a recipient site, you dig in the cell, you leave the periosteum. Initial, there are surgical procedures wherein they say you can expose the bone also. But the bone exposure will lead to a lot of amount of, but very good results. You get good results with it, but a lot of bone loss happening. So nowadays we don't advise using the complete bone. We don't expose the bone. We keep a periosteum over the tissue, give incisions, and you relieve the tissue here. You relieve the tension. I told you one of the setback of a tissue is that whenever there is a pull, you should always relieve the tissue from inside and make it free. Okay. Then you harvest the graft from the pellet. I told you this is the template. Okay, you have made a template here, and this is what are the basically measurement that they say 10 to 12 mm. You try to keep it at 3 mm away from the marginal gingiva of the premolars, okay, and the first molar, and try not to go till 12th mm. Okay, 10 mm and above, these greater than vessels are there. If you cut them, it will bleed heavy. So this is one thing I can show you. See, you leave a little bit of 2 mm or 3 mm margin gingiva and place the template and give incision all around when you are harvesting a free graft. Okay. Next I'll show you other procedures of correction graft. And you harvest a graft like this. You have given incision here all around and you slice it from the margin and take out the graft. The graft harvested graft is here and you know where you have plated. What you do is you put the graft here in the region where you want to fill and you put sutures. Okay, they have put sutures here. Okay, these are reciprocal sutures, and this is how after 6 months of healing you get good amount of attached gingiva. I told you increasing the attached gingiva, the best way is using a free gingival graft or any augmentation procedure. Mostly connective tissue graft also sometimes they say the connective tissue graft has a genetic role over the epithelium that is there. The epithelium that is going to come over, connective tissue decide what kind of epithelium is going to be there. So if you harvest a graft, connective tissue graft from a keratinized mucosa, the epithelium that overgrows it will always be keratinized. So connective graft also can be used. This is, but good is always the free graft. But the only thing is the tire patch appearance. Mostly you don't try to do this in aesthetic zone. You try and avoid in the aesthetic zone, but you can do it in the posterior region. This is one more example of a free graft wherein there was a recession and they want to increase the attachment also. This is what I told you, panning sutures, so that you don't get narrow dead space in between the graft and the recipient bed. This is what one of the procedure. How do you harvest a graft? The thickness I told you, the graft should be 1.2 to 1.5 mm. Whenever you get a thicker graft, unknowingly you try to expose, because of bleeding thing, you tend to get a thicker fat at the end. In the starting point of the incision, you are giving it a correct angle. But as you go at the distal area, you cannot control it because of blood coming in. You might take a thicker graft. So don't get apprehensive. Take out the graft, thin it. Okay, this is how you use this. See, they are holding it with the pliers and they are thinning the graft. Whatever the fatty tissue that comes out with the graft, you trim it out and they discard it and make it 1 to 1.5 thick graft and place it here. So this is about that. So Sullivan Atkin gave this idea about how much should be the graft and when should it see. This is about one thing. You should always stick to 1 to 1.5 mm of the graft. Some people say 2 mm also. 2 mm is okay when you are doing free ginger graft. But connective tissue graft always stick to within 1 mm. 1 mm is optimal for the connective tissue graft. Then there are varying techniques of the free ginger graft. Okay, there is a according technique wherein you give incisions on the sides and expand it. Whenever you have harvested a small graft and you want to increase the length of the graft, you do according technique. You give incisions on the both sides and pull it and place it. There is strip technique. This is also a good technique wherein instead of taking one big graft, you take it to strips. You use strips as the area to cover the area. This is also a good technique. And combination of epithelial and the connective tissue, the strip technique. This is also one of the techniques that's there. And whenever you are trying to say, let us say shallow palate is there, you are not, or patient is apprehensive and not able to give a graft from the palate side, you can always use the other areas that I told you. Acellular dermal matrix, very good results with ADM, but only the expenses are high. But ADM is a very good material, very good results. Okay, Porcan acellular dermal matrix also there. This is also expensive. Generic collagen matrix, these are coming into picture. Market derma graft is there. These are nice grafts, but expensive for maybe if a patient is payable, you can go in for a lot of this kind of. Means you are avoiding the second surgical side from the donor side and using this graft as a for your increasing the attaching level or the connection. Okay. What are the complications that can arise while doing fridge graft? First and the foremost is bleeding. Okay. Bleeding is sometimes becomes uncontrollable when incisal greater plateau versus. What are the solutions? What you can do? You can give is basically you can use a pressure pack. You hold on for 5 minutes, let the bleeding stop, then put those Howlis plate. Okay, that is one option. Or you can use electrocautery. Use those the ball tip electrocautery that you rub those vessels and seal those vessels. That is one thing. But negative of using electrocautery is there is secondary bleeding taking place after patient is stopped bleeding. Everything you send the patient, night it starts bleeding. So that's why you should use a Howlis plate whenever you stop the bleeding, so that it will, even if it bleeds, it will bleed inside the tissue rather than coming out of the tissue. And one more technique, easy technique I'll show you when hands-on, is suturing the greater plateau vessels. I'll show you rather than the palate. You can suture the greater pattern. Just suture it and tie a knot so that it will basically the blood vessels which are open, they get engulfed and the bleeding stops. This is one easy method, easy technique to reduce the bleeding in the palate area. Or use the hemostatic agent like Surgicel. Lot of things are there nowadays. Any dental conference you go, lot of materials are available. You can use those Surgicel or materials or cellulose materials. Place it there and suture that area also. That also is very good for controlling the bleeding. And how to, one more issue with the graft that you harvest is very smooth and it is very viscous and it is not easy to hold. So what you can use is you can buy these graft pliers or constitutive pliers to hold those tissues. It's very delicate. You need a good assistant who has certain experience in how to control bleeding and how to hold the tissue. Otherwise it tends to slip while from the tweezer and go inside a tongue, or it will fall down somewhere and it becomes very difficult to find it in the oral cavity with a lot of bleeding. So you should have a good assistant who will hold the tissue when it is harvested. Okay. This can be done with a graft pliers or a constitutive plier for suturing. This was Joe 1963 gave the first free-mirrored graft technique. Very easy. This guy was good and he said easy technique he gave us. But animal studies in the healing they say found out that by this Oliver and et al. And Roberto et al. They found out that how does the graft heal? There is first 0 to 3 day is target circulation, wherein the graft gets harvested blood from the inner tissue that you harvested. Okay, resuscitation phase takes to 22 to 11 days, wherein new blood vessels are coming in, angiogenesis happening, blood vessels are getting formed. This is the important period. So you should maintain whenever you use a fridge graft or candy graft, you should always keep the sutures for 14 days, minimum 10 days. So don't, just like any flap surgery, what you do, you take it out after 7 days. So I would not advise you to take out your sutures until 10th day to 14th day, ideally 14th day. Keep your sutures, if you are using resorbable sutures, don't take them out at all, they will resorb by themselves. If you are using silk suture or non-resorbable sutures, keep them, those sutures for 14 days and then only try to take out. Let us say you called a patient on 7th day, you take out the pack, repack again inside, so that the tissue is very competent to attack the underlying periostem during the revascularization phase, wherein the more failures happen during this phase. Then that for 11 to 42 days tissue maturation, the blood vessel angiogenesis has taken get reduced down, the number of blood vessels come down, the tissue merges with the adjacent the recipient tissue. Now next comes the free current tissue graft. This is a little technique sensitive, if you are able to, there are a lot of variations of how to harvest a connective tissue graft. Connective tissue graft with coronally advanced flap is the gold standard for root coverage procedure. Just remember, the coronally advanced flap with connective tissue graft is gold standard because you are using a epithelial tissue very good for a lot of very good results with coronally advanced flap. Okay, here is one example of connective tissue harvesting. They have created this is the area that there is a recession. They have created a recipient region. They have given incisions here and drained the tissue. Okay, they have drained the flap slowly. And now from the palate they are harvesting a single incision. This is called a single incision wherein you use only one incision rather than trying a trapdoor. I will tell you different techniques. Trapdoor technique, L technique, there are different techniques. But single incision is, if you can learn it, in a high lateral wall, very predictable. You tend to, this is nice procedure with the least amount of bleeding, least amount of complications because when you suture back here, there is no raw tissue. Means the healing takes place by primary intention. But you may never use a fringe graft wherein you have taken the epithelium out with the connective tissue. It always heals by secondary intention. So it's always good to use a suturing technique wherein the single incision or a trapdoor technique wherein you try to aim for a primary intention of healing. So what are the advantages of this? See, this is the graft, connective tissue graft that is taken and they have made the connective tissue graft and sutured it. Okay, and what they do is they coronally position the tissue and suture it. This is how it looks after 1 week and this is after 6 months. You can see that the recession correct takes place. The advantages of free connective graft over free tissue graft is that in the primary closure and tissue release of first intention, primary intention, less discomfort to the patient because you have no raw wound, so less painful to the patient. Improved aesthetics and color match. I told you about free tissue graft as a tire patch appearance. We tend to maintain a pale color compared to normal gingival color. In case of fringe graft, that negativity is avoided in case of whenever you use connective tissue graft. Then there is another technique for very predictable technique for increasing attached gingiva apically displaced flap. Okay, if you know how to suture periorbital, if you are well versed with periorbital suturing, okay, periorbital suture you don't use a pointed needle. Okay, you use a blunt needle because you don't want to tear the periorbitum that you are suturing. So if you can do that, this is a very good procedure to increase the attached gingiva, apical displacement. Only negativity is you are creating recession. You are creating anesthetic, not for the aesthetic zone. You should never do this procedure because you are keeping the tissue at a apical to the region. There will be a lot of recession happening. That is the negativity of this procedure. But this is a very good technique, very predictable. One of the technique for increasing the attached gingiva. Okay, this is also technique for pocket elimination. You know pocket elimination and pocket reduction. Pocket elimination, there are only two procedures that are pocket eliminating, basically apical distal flap and gingivectomy. Okay, this is one of the techniques for the pocket reduction as well as for increasing the attached gingiva. And there are three ways you can suture when you place it apically: slightly coronal to the crest, at the level of the crest, and 2 mm short, means you are exposing certain amount of bone. But best results are seen with this. Means the amount of attached gingiva that increases is very good in case of this procedure. Then there are treatment of the root coverage procedures. There are different ways you can use different surgical procedures to cover the root, that is the recession that is taking place. Basically, you can use this rotation flap. Means rotation flap are basically the flap. Means you are not. It's not a fringe graft. Okay. Basically there is a pedicle graft. Means the tissue is attached to the underlying tissue. It is not free. So there can be lateral displaced flap or lateral position flap or a double papilla flap. You take it from two sides and suture it to center. The negativity of double papilla flap is that in the center when you suture, it tends to get less blood supply and causes recession or a cleft type of defect in the healing phase. That is one negativity of the double papilla flap. The advanced flap are basically coronal position and similar. Coronal position flap is very good, very predictable, nice root coverage. if you have good amount of attached Java. Okay, otherwise there are two type procedures where you can increase the attached Java, apply to the recession. Then when you have a good amount of attached Java, you can coronally motion. Then one more. Cellular flap by Turnout. Okay, it is a nice flap for maxillary teeth, not very good for mandibular teeth. Nice flap for canine vision or maxilla. In the maxilla, I'll show you that technique. Very good, very predictable results. Nice procedure, easy to do. No bleeding, nothing, simple one. Nice procedure to do. But only in the maxilla, not very predictable in the mandibular. Then there are free tissue grafts, basically non-suburban free tissue graft, and two stages. I told you two stages means free tissue graft. You increase the attaching jaw and coronary position. That is the second stage procedure. This is the two-stage procedure. A suburban graft means you are covering the graft. If you are covering it, you can do it. It's called as connect tissue with lateral distal flap, connect tissue with double pedicle, connect tissue with double patella, and another flap. Or the Duchenne has given this nice procedure called as another flap. This is subepithelial tissue graft plus coronary advanced flap. This is the best out of all the procedures that I mentioned here. Then there are additive treatments, root surface modification. Lot of things were tried out. Okay, root biomodification was a hot topic in 1990s. Okay, a lot of root conditioners were there. There were citric acids, there were tetracycline, EDTA, but long-term results are not very good. But EDTA has shown good results. You should never use a citric acid because acids tend to create later decomposition of the necrosal tissue. So you should not use citric acid for root conditioning. You can use EDTA, which is neutral pH. So use EDTA, that is the best out of the option. Animal matrix derivative, I told you porcine origin. This is very good, shown very good results. Just using coronary flap with animal matrix derivative. Good results, lot of good results. PSR dermal matrix and GTR, you can use non-resorbable and resorbable type. I'll show you the technique. GTR, you can expect bone also to grow with the tissue. Sometimes not very failure happen because of reduced blood supply when you use bone drop also. But these are techniques that I just want you to know as a postgraduate student. Jigma, ginger augmentation, coronary to recession or the recession correction, basically you can do is Miller-James free tissue graft. Not very predictable when you don't have when you harvest a small graft. If you harvest a big graft with blood supply coming from lot of areas, you can expect certain amount of recession coverage with free tissue graft. Free connective graft, very good. This came in 1991, Levi gave it. Pedicle autograft, basically I told you lateral quotient, coronal quotient and similar Carnot flap, I'll show you. SCTG, I told you Langer given by Langer. GTR and post tunnel technique. This is also a very good procedure, but technique sensitive because you have to use certain amount of loops or small blades to cut those patellas. You have to pass the suture under beneath. So these are the things that you can do later. The pedicle graft, basically pedicle graft is, I told you, graft is just moved from one region to other region. Means you have given incision, you have a recession here, you take it graft from the adjacent tooth and move it to the recipient side. Means the graft is not free, it is attached below. That is what is pedicle graft. Okay, this is about group and Warren giving. This is an old technique. During this time, group Warren technique, there is a lot of modifications have taken place. This is an older technique, just to show you how to show. And lateral quotient flap, the coin was done by Hadler. Okay, this he says, this technique says, prepare the recipient, you create that, you do scaling, root planning of this region. They advise root conditioner using EDTA or tetracycline. Tetracycline capsule, you take out that capsule, put the powder, mix it with a little bit of saline, and that's good because tetracycline has got certain antibiotic. It is antibiotic, so it has got antibiotic properties added to the taking out the dentin also. Very good also. And prepare the flap and transfer the flap. See, they have taken the flap from this side and moved it to the adjacent tooth and sutured it here. This is the lateral display flap. What I would suggest is, if you think, but root planning, taking out all the remnant cementum over the area that you want to recipient area is a necessity. Okay? Take out all the cementum over it and create a dentin, because the dentin and tubules will open up and those will help in healing, attaching of the correct fibers that are there. So you can try do good root clearing of this region and to use tetracycline or EDTA. So they are one good root conditioner. I'll show this is one technique of lateral display flap. This is taken from Duchin textbook. Okay. This here there is a recession and he want to take a graph. He has measured the measurement. Let us say there is 3 mm of recession in the width. So you should think of at least bringing out 6 mm. Means 3 mm of tissue and 3 mm over the two surface, 3 mm adjacent tissue. So what they say is take a bigger graft area and you give incision. See, this is the recession area. They take out the graft from the adjacent tissue, leaving out the marginal tissue. Usually has modified this lateral display flap, wherein they move the tissue from the area and bring it to this recipient region. Maybe use EDTA and root condition. This C. He uses EMD. Okay, element matter derivatives. He uses a lot of in every technique. Usually uses EMD and he switches the graft to the recipient site here. He has moved this tissue and sometimes from the donor side, if you feel that there is some tissue happening, you can put a fridge graft or to cover that region. That is, or you can use Surgicel or some coagulating agent or PRF. PRF also can be used as a nice thing, because if you are trying to avoid the fridge graft, you can create a PRF, spin it, and do you know how to prepare PRF? Take 5 ml blood and spin it. There are certain lot of techniques. There are L, PRF, T, PRF, all those techniques. I'm not going to tell you how to harvest. PRF can be used also as to cover the donor site. This is one other way of doing lateral quotient flap. This is one diagrammatic representation or a photograph of a patient wherein they harvested a graft. They created the recipient region. They harvested a graft from because it's a pedicle graft, it's attached to underlying tissue. They moved that tissue to this region and sutured it. And you can see the good results that are happening with this tissue. No color mismatch, good result, easy to perform. No bleeding. Whenever in case of harvesting graft from palate, the biggest issue is the bleeding when you cut those vessels. So what Duchin says is that don't go below 1.5 km into the tissue. The blood vessels are around 2 km and below into the palate. So if you can stick to your graft thickness to 1.5, you can manage without the severe bleeding. If you by chance somehow misplace and go deep, if you cut the vessels, it bleeds like hell. The one tool, that's easy. There are techniques. Okay, suture, I'll show you. Possibly in the hands-on, I'll show you how to do that. Lateral display flap, varying techniques are there. Are different varying techniques. Lot of authors did lot of things. There is rotation flap, oblique rotation flap, transposition flap, double papillae flap, from two sides, coin rows cages, and sliding partial thickness flap. These are all different modifications, varying techniques. You can try it out, but I would say simple lateral display is a very good procedure. Okay. The modification that were given was Korn in 1964. When you have a pull, when you have displayed from one region to another, if you have a pull of this tissue happening, can give cutback incision. Cutback incision is given to make the tissue mobile and without being pulled down. Okay. And group modification, he gave modification instead of group, he was said instead of taking out the marginal tissue, they leave out certain amount of marginal tissue in the recipient side. It helps in suturing also. Duchelli gave the protected margin. This guy, Duchelli is the one nice. Lot of YouTube videos are there. If you are interested in Duchelli periodic pattern surgery, lot of nice videos are there. If you are interested in learning these things, you can see those things. This guy also says instead of cutting the marginal gingiva, you leave out certain amount of marginal gingiva. It will help in healing and better aesthetic results. Okay. And usually these people say that by healing happens by secondary intention leading to resection of the recipient, the donor side. This is one activity of the lateral display flap. So if you can somehow leave out the periosteum and use a parietal or a PRF or a graft over the donor side, you can get a good result with lateral display flap. How does the healing of a lateral display flap happen? This was Wilderman and Wendt in 1965 did animal studies. Okay, these are not directly human studies. They say in adaptation stage, the 0 to 4 days. Proliferation means from the epithelium starts growing and the older epithelium gets decomposed, necrosed and new epithelium gets formed. The attachment stage happens in 21 to 28 days and maturation takes from 28 days to 6 months. They followed up the animals till 6 months and found there was still tissue remodeling happening in case of lateral display flap. Coronal display flap, this is the very easiest of all the periodontal practice injuries. Just cut out from this one, move it. But the first technique what was there was they just were placing it coronally. So what happened was, whenever you have inadequate attaching java, if you have moved it coronally, you are already there is less amount of attaching java. You are jeopardizing the tissue that is already coronally moved. Means ultimately it led to inadequate attaching java intercession. So the first technique was discarded. Now they say is the second technique or the variation technique is they say use a free ginger graft, augment the apical recession, augment the tissue, increase the attaching java nicely, then go for coronal advanced flap. This is one thing because these results were with the first technique were unfavorable and that's how they came up with the idea of increasing the attaching java, apical recession and then coronal positioning it. This is about this is the Duchenne technique, okay? Duchenne was you watch his videos, nice videos, okay? What he says is, he says partial, full, partial technique. Means, how does he say? See what he does is, I would want to explain this, okay? These are the incisions, vertical incisions given, and you maintain, from the seizure you give this horizontal incision and join these vertical incisions, okay? From this point to the recession point, till the point, you harvest a partial thickness flap, okay? This point to this point, till this point. You harvest a partial thickness from this point till around the amount of recession. Let's say you want to cover 4 mm, 4 mm till that point, you harvest a full thickness graft. Very technique, but use a blunt dissection. After split, always see, partial thickness flap is only possible through the sharp dissection. Use a blade to cut it out. Whenever you are using the full thickness flap, use a perioptal elevator to elevate it. Okay? He says, elevate this from this point to the recession depth, you measure it and you go for full thickness flap. From this point to the deeper, till the mucogingival junction or further than that, you once again start partial thickness. You cut it from the inside tissue. I'll show you that. I'll show you. Okay. Okay. From this point to this guy said all these incisions are extended till the vestibule, okay? And you partial thicknesses and move this whole tissue coronally, and you deepithelize these capillars either by crisscross incisions or if you can nicely slice out, very good. If you're not able to slice it out because of time constraint or maybe bleeding, you can give crisscross incisions so that the whole epithelium get distorted. The new tissue that you move, you can coronally position it. Here, what he has done is he given those horizontal incisions, given the vertical incisions, okay. Then he is slowly excise the tissue, sharp dissection, the partial thickness flap, and from there he is going to make a full thickness flap. From this point to full thickness flap using a blunt dissection, and from that point he starts doing it once again partial thickness flap. From this point here, then he uses lot of EDTA and EMD, lot of things he does. Okay, he says EDTA as a root conditioner and EMD to be used, and then he coronally takes the whole tissue, moves it passively, make as the tissue that you are trying to coronally position, make it tension free. There is no pull. Make it tension free and suture it coronally. That is how this guy says, okay. But very good results with this procedure. This is one example of a coronal defect where two-step procedure means they are augmented with the fringing graft initially, wait for 1 month, 4 weeks. Put a fringing graft, wait for 1 month. When you have increased the attaching java, then you can coronally position it with just simple incisions, and this is one technique, two-step variation technique of the coronal advanced flap. Turnover, okay. This is a very easy procedure. Turnover incisions, not shallow, it's a wide incision. He says turnover flap is a nice incision, semilunar flap is given. Okay, so this is a two-step procedure. Okay, when you test semilunar flap incision on the opposite mucogingival junction, whenever you have a touching java, and you move it coronally. I'll show it to here. Here, what you do is you have a certain amount of research happening here. You give similar incision like this, and you give certain amount of split incisions like this. Move the tissue and bring it coronally. Sometimes, if you can thoroughly, if you have given nice incisions, you don't have to even do suturing. Just suturing this is, they have used suture just to see that banging suture where to compress the tissue. But even without the suture, in case of maxillary teeth, can do it nicely. In mandibular, this is not very successful. Sir, a lot of things are there. I don't want you to read all this. I'll explain this to you in here. How do you harvest the connection of teeth? This is a trap door technique. Trap door is you give incisions like this. You create a trap door and you split the thickness and take out the connective tissue graft. Okay, this is the donor side is once again sutured back and you harvest the graft. This is one technique. For beginners, I want you to do this trapdoor technique to harvest graft, because other single incisions, unless you master the incisions, it will be very difficult to do it. And how do you harvest it? You harvest the graft here to split the thickness, harvest the graft, and you close this suture. The donor side you suture it. Just that will heal by primary intention. This is the harvested graft that is there, and use this. There is one more technique called the L technique. Okay, instead of giving a trap door, you give L incisions, and you can use L incisions to only one and L. This is L incision, and you can harvest the graft using blades and needles, the small scissors that are there. But these are microsurgical scissors, not the normal suture cutting scissors. That you can use them to harvest the graft, and the thickness should be 1 millimeter. The ideal results are always with the correct graft is 1 millimeter thickness, and you place it here and suture it. Then there is a single incision technique. If you master the trapdoor or the L technique, you can go in for single incision, where you give only one incision. Okay, you give one incision. The upper part, so epithelium, slight amount of connective tissue, you slice it like this, slice it first. Then you take you go to the deeper level and cut out the tissue and take out the graft. Harvest it like this from single incision, and you can use this also. Little technique sensitive, but if you can start doing the procedure, you will not a very difficult thing. But a good pattern, high pattern word is a necessity, because the thicker the tissue, easier the incision to place. You will require the quadrangle BB handle. Here, this is Duchenne says, instead of trying all these high techniques to harvest a connective graft, he says simply take out a fridge graft, easy to do. Okay, I just take a fridge graft and then you de-epithelize. Means you take out a full thickness flap of graft with the epithelium, and you slowly cut it out from the underbeneath with a small 15C blade and take out the epithelium. This is called a de-epithelized fridge graft. Means you take out the fridge graft, you take out the epithelium and use it as a connective tissue graft. This is also a technique. I told you how do you control the bleeding from the donor side is you use surgical or some sponge material and suture that material. This will control the bleeding. This is one of the way of how to surgically bleeding is bound to happen. You should control the bleeding before you send the patient out. The summary of harvesting graft is basically I told you the trapdoor technique is you give 3 incisions, L technique is you 2 incision, and see this single incision, and the fourth one is you take out the fridge graft giving all 4 incisions and you de-epithelize it and make it connective tissue graft. These are the 4 methods how you can harvest a connective tissue graft. This is one example of I give by Langer. Okay, what he says is that you excise the tissue, split it like this, and put a graft over here and coronally position this and suture it. I'll show you next slide. Here. Okay. What they say is they give incisions like this. They But in lanyard technique, they were excising the papilla also. But nowadays, usually says don't excise the papilla, keep certain amount of margin gingiva above it so that you can suture it. This is one lanyard technique, older technique, but this is where you put a graft and you suture it. This is something that by lanyard, this is what I showed you, and this is a diagrammatic representation of two teeth with precision, and they have harvested a graft, put a graft and coronally quotient and suture it, and you can see the results. Then there is one more technique called as coronal advanced flap with bilinear CT graft. This is a somewhat similar GPL technique I told you. You harvest a coronal advanced, you recipient side, you create a incision, vertical incision, raise full, partial, full thickness, partial, full and partial incisions. Okay. He does lot of root canning and EMD every time he uses, and he places the coronal, puts a graft and coronally quotient it. This is one of the bilateral technique wherein you put a graft and over that you push in the coronally advanced and suture it. Pinny Prato, okay, these people were when the GTR came in, mostly they were non-resolvable type of GTR, so they advised to use non-resolvable EPTFE, expanded polytetrafluoroethylene, or the gold standard in the GTR materials. Okay, nowadays. That's pretty expensive, but you need to do second surgery to take it out because it's non-resorbable. So nowadays collagen-based resorbable GTR materials are available. You don't have to do the second surgery; you just have to put them and do it. Okay. Now, this technique says that I'll show you this. What they do is they rather partial thickness flap over here with the vertical incision. Then they place a GTR material. What happens is GTR is like a paper. If you have seen GTR material, Gore-Tex membrane, it is just like a thicker version of a paper. It is very stiff, so it will not hold on. So what they do is they put a suture in between some graft so that it will create a hollow space for the tissue to grow in. This is one technique of using, or there are titanium reinforced GTR materials now, where you can mold it, but expensive. All these newer techniques have certain amount of advantage, but the expenses goes up. You can use that also, titanium reinforced graft and coronally quotient it and suture it here. This is also this is a very good technique if you are trying to do bone regeneration with the correct tissue growth. Then the poaching technique, I will not talk about all the theoretical part of it. There are a lot of things here, but I will try and explain it here. See, what they do is, you have a lot of recessions in 3 teeth here, or 4 teeth. What they do is, they give partial thickness incisions, no papillae are, no, there is no graft created, okay? There is no graft created, or the tissues are meant to, the flap is not elevated at all. Flap is just give graft incisions all around all these teeth, join them here. See, they have joined it, they have, see, you can move that time. Then, they have taken a harvested connective tissue graft from the molar region or the palate sometimes, they say polar region also, but easier to harvest it from the palate than other regions. Okay, and then you can suture it like this and pass it on from one to the other, pass it on, and then you coronally quotient it and suture it. This is very good, but certain amount of skill is required. If you can do, if you are the youngsters, if you can invest into microsurgical instruments, use loops or microsurgery. Loops have the negativity is that you tend to have eye dysfunction at certain, after long time use, you tend to have eye dysfunction. So they say microsurgical instruments or a microsurgery should be used, but for that you need high hands coordination. Means you are looking like this and doing surgery like this, means certain amount of training is required to use a microsurgical as an instrument. If you can learn that, if you can invest, you can get very good results with all these techniques. The more the magnification, better the results with you, but the investment and the training part, the learning part, if you can do that as a youngster, the future of dentistry is all microsurgery. You should be buying loops or microsurgical instrument in the future. This is one tunnel technique wherein single tooth recession, wherein they have harvested a graft like this and they have created a pouch. In that pouch they have passed on the graft and sutured. Very good results with this kind of technique. And for multiple teeth, same thing, multiple teeth, what they do is they have, see here, they are given incision, capital incision, they have part the blade like this. You understand there is no flap elevated, no flap is elevated. It's the graft is slowly pushed down from the inside here and suture. This is one good technique to, if you are, but what happens is graft, continuum grafts are very delicate and very viscous. It's very difficult to hold, and as a practice, when you start doing that, all the grafts are very viscous, and even in the tweezer it tends to slip. So slight amount of handling the tissue, if you can learn through the process, it will be good for you. Technique to deepen the vestibule, a lot of techniques I told you, all is good with, I told you in my first presentation, class technique, all these techniques, they failed to, in the long-term results. After 5 years follow, they didn't show much results. So they say, augmentation with fringe graft is the best method of increasing the debut vestibule. See, what is a predictable deepening of vestibule can only be accomplished use of graft techniques and their variants, or EMD, or maybe you mostly use ADM, acerdermal matrix. Then only you can get good results. Otherwise, they didn't find good results. But in 5 years follow. Then there is the technique for splenectomy and phrenotomy. Phrenotomy is just excision. Splenectomy is when you expose the bone and take out all the tissues. That is splenectomy. Okay. There are steps I'll just explain them instead of trying to tell all theoretical. I'll tell you here. You hold a frenum is there. You hold it with a needle holder or artery forceps. Hold on. Q2 incision. On the top you cut it. On the base you cut it, and you get this trapezoidal tissue like this. And you should suture this at least. Whenever you are doing in laser surgery also, same thing you can do, cut it out. But always suture, my advice is always suture the coronal part. If you don't suture the apical part, it's okay. But the coronal part, you should try and suture. This is the way of doing splenectomy. Technique to improve the root coverage, papillary reconstruction, and therapy to correct excessive ginger. I'll show you all this. See, papillary reconstruction is very slightly, this is the back triangle that is being formed. Very difficult sometimes, okay? Because the papillary reconstruction, the success, they tried a lot of things. They put grafts, they tend to get necrosed. So what the best technique at present is, the technique given by several surgical pouches. It means you create a pouch from the top of it. If there is a recession triangular, you harvest it, you raise the full thickness flap here, and take out a connective tissue graft from the palate, and you push that graft and put the whole tissue, from the base, you push the whole tissue and put it here, and then you suture. This is what is the results of. This is one of the way of predictable results. Otherwise, lot of techniques are there, simply raising the coronary flap also, but the black triangle thing does not get solved whenever there is a red position there. Papillary reconstruction, but this is one technique wherein they have used bone graft, GTR, connective tissue graft. They have given several incisions here, raised the flap. This is the connective tissue graft. They put a connective tissue graft over it. Somehow they use those pins. Have you seen those pins? Tags. Okay, you can use those tags and stabilize this graft that is used. And you can put they have used bone graft also. They have put a bone graft over it, and they have sutured it. And this is how this is the tag that you put in. Okay, this is how the reconstruction of papilla is taken place. With this, not just you cannot get 100% result, so you have to create certain amount of restorative work also. You have to create these crowns are modified slightly so that the papilla gets filled in. Means this crown they are modified here and make it to 8%. Even restoratively also you can cut the black triangle that is there. Aesthetic crown lengthening, gummy smile. This is one of the procedures you should be doing because lot of the people are aesthetically oriented. They don't have margins which are at the same level. Okay, this is one easy procedure. Okay, wherein you can raise the flap and maybe do bone resection also and give contour. The margins are contoured and then the suture back. It's just like a normal flap with bone contouring, bone resection as well as the flap closure. Bridge augmentation can be done through different techniques. There is a pedicle graft, it's roll flap technique. free graft procedures like post graft procedure, interpositional graft procedure, and on-leg graft procedures. Okay. Here, this is the roll flap technique, means there is no. This is a pedicle graft, means you are not excising free. It's not a free graft. Wherein you take hold of the tissue like this, harvest the graft, and you fold it. You roll it and create a. This is the roll flap, where you ridge augmentation through soft tissue. For prosthetic purpose, you can do this. And this is a pouch technique by wherein they have laid a flap, harvested a current tissue graft here, and placed it and sutured it. This is also very predictable. Different variations of where you can place this pedicle, the current tissue graft that is there. This is interpositional graft. Okay, one easy technique. If you have a Sibbert's class 2 defect, do you know defect ridge defect in a Sibbert? This Sibbert type 2 defect, you can just take a current tissue graft, harvest it, place it interposition and suture it. Predictable results with this easy technique. Predictable results can be achieved. On-leg graft means you are putting graft on leg is easy. They have plated this here. They use both interposition as well as on-leg graft here. Means they have plated an on-leg graft as well as interposition here, so that the blood supply is maintained. This is the on-leg graft with combination of interpositional graft. This is one technique of on-leg grafting wherein they found that there was certain amount of ridge defect here. They gave just excise the epithelium, took a free graft, plated over this, and they can see the results of this. Now talking about tissue engineering, I told you there is passive engineering and active engineering. I told you about all this GTR based and biologically ADM is available. These are already, means there is no, you are not activating any cells. You are just using what is already available. That is passive engineering. Active engineering is using by environment matrix derivatives, growth factors, or PDGF, all those factors. Cell therapy means autologous fibroblast, bilads, BSC stairs, and HFBDs. This is basically derma graft harvested from the xenogenic graft. Okay? And active tissue engineering can be done by using of EMD, environment matrix. This is a very good material. Only thing is it comes in syringes and one-time use. So if you can keep 2-3 patients in one sitting, you can use that very good material. Okay, very good predictable results with EMD. Then the active we can do it with human RHPDGF plated with growth factors. You can use them. Okay, plated growth factors, beta tricalcium, that is bone graft. They use bone graft with the GTF, PRF as a membrane. Okay, and this is also one of the techniques to achieve. So what are the alternatives to soft tissue grafts? If you cannot harvest a graft, what you can do is you can use this acer matrix, which is very good. As ADM is but expensive but good one. In EMD also can be used. Collagen matrix, HCM are all available. These are Porcan derived materials. And Gislich has got 3 different variations of this graft. Okay, HCM. Okay, mucograft seal and fibrocard. You can watch videos of this also. Nice. If patient is payable, good enough, then it can be tried out there. Easily available material, easy to operate also. And then Porcan, PADM, Porcan matrix. This is also a good material by Germany, the Biotis company. And this is also just like ADM only, it can be used. And tetracycline fibrin, this is for Indian population, this is the best because it does cost effective. You can just use the human blood, patient's blood and use it as a son. This is my study, okay, my study. We did a study and published it in IJTR. Means is plated fibrin viable alternative to SCTG. This was what we did, and we did a split mode study where on one side we did SCTG in a subdivisional graft, on the other side we used PRF, and we came to the conclusion that PRF can be considered as a viable alternative to SCTG. Means we found not very good, better results, but commendable results with just use of PRF instead of SCTG. What are the characteristics for perio-plastic surgery? Surgical site free of plaque and calculus and inflammation. Means you should educate patient to maintain good oral hygiene and take out all the plaque and calculus. Adequate blood supply should, after donor site should be available. Anatomy of the donor site. Anatomy of the means whenever you have a curvature, the root is bigger, you should trim it and make it flat so that predictable results are there. If your tooth is labelly plate, you can avoid doing surgery because the results are not very good. You should always place either orthodontically move the tooth and then do it, or you should trim the tooth on the outer surface and do it. Stability of the graft, that means I told you, you should not be movable, you should be tension free. Minimal trauma on the surgical side. This can be achieved through microsurgical procedures or use of loops, which will give better results with the result. What are the, I told you, these are same factors I told you, patient factors, side factors and technique factors. I tried actually because I put this slide again so that this will remain the reminder for people to think. These are my references. I would like to acknowledge all those authors and for using their photographs. And I would like to thank Dr. Tomar sir, Chairman and Chancellor of the University, Dr. my good friend, Dr. Sunil, the Principal of School of Medicine, Geeta Bhargav, the HOD of Perio-Plastic, and all the organizing members of the Perio-Plastic Surgery. And I thank again all of you. Next I will.
Our sincere gratitude to you, sir, for such an enriching session. You have possibly touched all the procedures for perio-plastic surgery in a very concise and in a very systematic manner. And also, sir has very graciously shared with us the tricks of the surgery and how to deal with the surgical problems at the time the patient is there with us. Now let us move forward and we will start with the demo.
I have some issues with my foot. And use this instrument very slowly. Just lock it, and when it gets locked open, see there are two things here, getting it locked. Just smooth, move and lock. It gets locked. I hope you are seeing it. And when you want to open it, just open it like this. This is one thing you should know about the cataract pattern needle holders. Very delicate, but good for doing a small, because the bigger needle holder. Okay, even these are easy to do in case of flap. The needle is bigger, if you are using the silk suture, mostly the 3x8 needles are used. Okay, those are bigger needles, good when you are just passing. And one more thing which I want to learn is, whenever you are suturing, the only movement that should be happening is your wrist. Wrist movement is one thing for non-periodontal PGs. If you are doing it for the first time, wrist movement is one thing you should learn, because the suture needs to be moved like this. Your wrist is one thing that is, you have to learn to use the wrist to suture, because you have to rotate it around some either half turn or half curve or a 3x8. All those are in some curvatures. So you have to curve it according to the needle, then only it gets passed on. Otherwise, if you are just pushing it, either it sometimes get stuck in a bone, might bend, might break, all those issues. If it breaks in the palate, it is very headache to take it out. We had one PG who broke a needle in the palate. We had to take her to CPCT room, get it engaged, and all. You end up in a lot of complications. So try and see that you don't break the. Whenever needle gets bent one time, discard it and take a new needle. Don't try to recorrect needle and do it, because it has got certain amount of strength and it will break at the same point where it is bent. So avoid using these kind of things. Okay. What I want to show today in this is, I am trying to show you. I'll first create a recession, slight recession somewhere, so that you will at least. I am not sure how good you will be able to see this.
Come forward. If you are not able to see at the back, please come forward.
Okay, I'll just create one recession. But see, what happens is here, the tissue is a dead tissue. There is no blood. It is not differentiating between the tooth and the sun. But I just try to create a recession here. Hopefully, it is visible to you people.
Come back. This is a demo, and so again.
Or you take a chair so that the focus get changed. Okay. What we do is, you want to, let us say, hopefully you will be able to see I have slightly created recession kind of defect here. Okay. I mean I have taken out the tissue. What you do is, you give two horizontal incisions like this at the CG level. Okay. Hopefully you are able to see. If you are not, are you able to see or no? Okay, you are able to see. I am giving this horizontal incision like this. Then I am showing you coronally advanced trap. Okay. Remember. Then these two horizontal incisions I will try and connect with a wide vertical incision. Means you understood what wide means. The base should be wider than the apex of the lesion. Means here is one more incision, here is one incision. I connect it like this. Go till here is not exactly showing you mucogingival junction. Go beyond the mucogingival junction into the vestibule slightly here. See? Hopefully you have seen this part of it. Okay. I have given you incisions, 2 vertical incisions and 2 horizontal incisions on the recession region. Okay. Now, what Duchenne says is that you do 3 type of exposure. Split, full, split. Remember the split, full and split. Initially, what he says is that the tissue is too thin to show you. Here, you split the tissue. I am trying to keep as much light as possible. Here, you split the tissue till the amount of, let us say you have 4 mm amount of recession. Till that 4 mm, you split it. This is a very thin tissue, okay. I am just, hopefully you will see what I am trying to show you. Because I have split this tissue here. Let us say this much amount of recession is there. From that point onwards, what he says is, okay, okay. Okay. From this point onwards, okay, where you have done split test, he tells the amount of recession, whatever that, he tells you to raise a full thickness factor, means blunt dissection. Means I am using a periosteal elevator without cutting the tissue, I am raising the tissue now here. Are you able to understand what I am trying to do here? In a live tissue, this will start bleeding and you will at least see what changes are happening. In a dead tissue, this is slightly okay. This much amount of, let us say I did a full thickness tissue closure. From that point onwards, okay, from the point that was there, okay, here, from this point onwards, what he says that go for split thickness again. Means you excise the tissue, and you can see it here, I am splitting the tissue so that it becomes movable. In this animal model, there is no free mucosa. It is a dead tissue, there is no free mucosa. But in case of in the oral cavity, when you start splitting it from inside, you can see that tissue starts becoming free and you can coronally position it. Okay. This is, I am trying to show it somewhat, this is all attached here, but I will try and show you as much as possible. From this point onwards, I am splitting it. Okay. This is a very thin tissue to, okay. I have split it like this. Okay. This, what, here, this small, there is no free mucosa to move it correctly, so I will go inside a little deeper than the necessary. The tissue is pretty thin, okay. But in humans, this is thicker than this, don't worry. You split it like this, okay. It is pretty thin tissue. Anyway, what happens is this is not really movable now. What we do is, we use a custard pattern, little older. This is half circle needle, okay. You engage it like this. Okay. When you are engaging, one thing you should remember, this is a very delicate instrument. Just slowly lock it. It is locked now. Okay. When you lock it now, then mostly corn plier is not here. Okay, anyway, mostly if you are not able to find any instrument, you should use a corn plier to suture. Corn plier is easy to hold and you just pass it like this. This is a very thin tissue. Okay. You pass it like this and you corally position it and you suture it to the papilla. And your hand rotation is the wrist movement is the only thing that should be doing. When you do that, slowly disengage this instrument, okay, and hold it here, lock it again, avoiding the tip. When you come out, try and do it with this hand because with the instrument you might tend to lose the tissue. Slowly pass it down, pass it down. Keep only around 5 millimeter size, 5 centimeter of the tissue, the thread remaining, so that you can use it. If you knot it there, it will once again get locked. Because this is an expensive suture material, keep it at 5 millimeter. Let us say this much is 5 millimeter. Keep this much remaining and complete. Yeah. Then you know the different type of knots, surgeon knot, nanny knot, all those knots, the surgical part, okay. You throw a double like this, double throw clockwise, okay, unlock it and single throw anti-clockwise. When you take it out, you can just pull it with your hand. Then you leave around scissor. Anyway, scissor is out here, no? Cut a suture. Okay. What you do is use a scissor and you cut around, leave it around 4 millimeter. Hold it. Instead of this is not the exact method. Use a technical suture cutting scissor and leave around. He left too much material. To around 4 millimeter to 5 millimeter free thread, you cut it with the scissor. Okay. Suture cutting. Same thing you do on the other side also. That is how you can corally position the flap that is there. I told you one more thing which I missed was the de-epithelialization. Because there is this tissue is too thin, I might expose the bone only. That is why I am not de-epithelializing. Mostly, you have to de-epithelialize the papilla that you are going to try to pull. Here, the tissue is too thin. If I de-epithelialize, the whole tissue will come out, the bone will get exposed. Same thing you can do on the other side. Move it slowly.
Max.
Okay. Now, here you gave this instruction, then you once again go back and lock it to the papilla. I have not de-epithelialized the papilla because the tissue here, this model, I might tear out the whole thing. Here, you come to scapula and suture it. The only thing movement should be your wrist. Your wrist should move this needle. If you are first timers, do it outside rather than on the patient, because you tend to miss out on a lot of things while doing in the patient, because it will be bleeding all those tissues. Then you just hold this. Then I told you 2 throw clockwise, 1 throw anti-clockwise. So you technically coronally portion it, but here this tissue is too thin for you people to understand. I hope, did you understand what we did here? We have coronally portioned this tissue, and this is not moving further. In case of oral mucosa, whenever you come to after mucogingival junction, the tissue becomes free. What you do is those incisions in a patient, it is easier to sew than this here, this model. Okay, you just have to incise from the instrument. You can move it coronally. Nicely, you can make it free. Go as deep as possible. You can move it to as free as mucosa without the tension. Suture it so that there is no tension when you suture. There should not be tension on the over the tissue. There is no scissor to cut it. You will cut it. 3 to 4 millimeters. You need good scissors, good blades. Okay. Whenever you are doing free ginger grafting, a good blade is a necessity. If you are feeling that you are not cutting it properly, discard a blade, take a new blade always. If you are given a recipient site you prepared with one blade, don't use the same blade to use the harvester graft. Okay. In the second, whenever you are harvesting graft, always take a new blade, and the cutting should be very precise, as because you have to slice the tissue. If you are blunt, using a blunt blade, you tend to create tags. Those tags will hold on and not let the tissue fall out. So either in that situation, either you can use micro scissors. Micro scissors are 1/10 of this size. This is a big size, 1/10 of this size, where you can use those micro scissors to cut the tissues. But that is only possible when you are using microsurgical instruments. When you learn all that in that. See this. This is about. I'm not sure how good I am able to show this to you people. This is about coronally advanced flapper, easiest procedure. In the same procedure, you can harvest a connective tissue graft and place it beneath this and coronally position it and suture. That is the gold standard. Subepithelial connective tissue graft is the gold standard for root coverage procedures. Okay, and free ginger graft is a gold standard for increasing the attached gingiva. If you are not having able to harvest a tissue from the donor side because of the shallow palate or the patient is uncomfortable, you can use acellular matrix or some grafting material from which are available commercially, mucograft. There are commercially available grafts now, which you can use either animal origin, porcine origin, or bovine origin also. It's come, but it's not. Porcine origin is the best. So these can be used to suture the you can use instead of a corrective graft, you can use this also. ADM is a bilayered membrane, okay? It is a bilayered membrane. You can use it as a free ginger graft also. That has shown very good result. But only thing is, it is very good when you are coronally positioning it, covering it. If you are keeping it open to the oral tissue, it tends to get decomposed. So, you should, if you are using ADM, think of coronally advanced flap with a ADM or a connective tissue. That is the best procedure for doing this whole procedure. This is the one thing I am showing here. Vestibular deepening or this open, at least the goat maxilla is there. Goat maxilla. Maxilla is the. I'll show you maxilla, one easy technique to solve the bleeding from the greater palatal vessel. I've been talking and talking. Hopefully people have.
Sir, you said that we should harvest a graft from the palatal region and it should have a clearance of 1.5 mm so that we do not hit the nerve artery. But in the anterior region we have the incisive foramen where there is a main nerve supply.
No, inside the area till canine you should not harvest on top because in the palate there is a rugae area.
Yes.
Check your palate. It is not soft, it is rugae. That region is less compared to the mid area. I told you 1/3 of the part of maxilla don't harvest, the posterior 1/3 don't harvest. Middle 1/3 only you should be using it as a graft. From distal to canine till the mesial of second molar. That is the best area to harvest graft. This is a small area. If you are thinking of bigger graft, the only way is wearing technique, wherein either you use strip technique or accordion technique to increase the attaching jaw. This is a very small area because the maximum graft harvesting you can get is 12 to 13 millimeter in length. Width you can go up till 8 to 10 millimeter, that's all. 13 by 10 is the maximum biggest graft that you can harvest from palate area. If you are thinking of bigger area, you can do it on both sides. You got it, na?
Yes.
And don't try to come to the center. Center is the palate has got closed area. If it gets opened up, bone necrosis can happen, and that is also not good area. The only area is I showed you that one side, 10 to 12 millimeter. I'll let the palate come. I'll show you that area. That is the best area for harvesting bone graft. I mean the tissue graft. And anybody else not understanding what is the whole thing about? I'll show you how a graft is harvested. Yes. The rugae area, you will never get a flat graft. It will always be elevated. This is not a good area for graft. Same, somewhat similar in case of, this is a goat head wherein there are no teeth here. Here in the anterior there will be teeth, anterior teeth. Till canine, not at all good. Distal to canine, till the second molar, mesial of second molar is a good area to harvest the graft. Okay. Here, well, let us say you want to harvest a graft here. Leave around 2 millimeter to 3 millimeter marginal gingiva intact. I'll show you. I'll just one I'll show you. Okay. This, you leave around 3 millimeter. You put incision lightly like this. Okay. Connect them like this. This is all movable, but in case of the natural, it will not be movable. Okay. Then you connect this. This is the area where you can harvest a graft. Okay, when you start now, I'll start from mesial because if you understand it. One thing what you can do is you should I have my incisions here. I'll start cutting it like this. This tissue is little movable. In case of hard palate, it is a fixed tissue. It is not movable. Okay. The incisions are nice. Okay. Here, you start incising like this. 1 mm is adequate. 1.5 mm is adequate tissue. Oh, sorry. Okay. You start incising like this. You start splitting it all. Split tissue. Once when you get a cut, what you should do is, you should do no. This tweezer don't use because it will create holes. Don't you want to preserve as much as tissue? Okay. Those tissue pliers are there. You once you exercise a certain amount of tissue, you can hold it like this, and start cutting it more. Here, you start cutting it like this. Okay, you get a graft like this, small version of the graft. Okay, what they say is, it should be 1 mm thick. The graft, hopefully people are seeing, it should be 1 mm thick. As you go distally, mostly, what happens is, your incisions go deeper, so you might tend to cut the vessels. The solution for this, I have harvested graft, I am just showing it here. The solution is, the one either, where is the suture? Is there? One easy thing is, you can take a silk suture with a 3x8 needle, bigger needle also is fine. What you do is, just you locate the bleeding point. When it starts bleeding, you will see the blood flowing out and all that. There will be a lot of bleeding. You locate the bleeding point and just give one suture like this. Are you able to see? Let us say there is a bleeding point here. You go here and come out.
हल्का पीछे रखो, थोड़ा सा पीछे बस, लाइट रखना है।
Are you able to see now? You come out here like this. And put a knot. Okay, one and two anti-clockwise. Okay. Give a knot like this. This will compress the blood vessels, greater blood vessels, and bleeding will reduce. But always use a Hollis plate over this. Here I am not able to. Hollis plate and either use a Surgisil or some cellulose material. Put it over here. You can suture like this also. You can put those Surgisil material, keep it over this and suture like this. Are you able to see what I am doing here? This is one thing you can do, you should be doing to control bleeding. Bleeding is the biggest complication in all these free-general graft and cut tissue grafts. Okay, this is one thing you should be doing, and cut the suture. Okay. This is one thing you do to control the bleeding, and Surgisil or some sponge material to control bleeding, and Hollis plate. These are the three things that you should be doing. Next I'll give you chance to do yourself in the hands-on. You cut, but don't get that. My whole thing is don't get excited and start cutting. Don't butcher. As minimal tissue damage, as incisions slowly as you can do. That is the best way of doing the surgery. We'll try it out. You try hands-on. You try out different techniques, and we'll see how best can be taken. Okay.